Welcome back to the meeting and the next session. We have now 3 case presentations, and we will start with one from Bonn. I'm happy to invite Jürgen Rockstroh from the University Hospital in Bonn. He's the head of the HIV outpatient clinic, to present his case. I think it will be a co-infection with HIV and HCV. And I inform you already now that Jürgen has to leave after his presentation directly because he has to go on a difficult topic. I think it's vacation or something like this. And but he worked hard for a long time, so I think we are fine with this. So we will have the questions directly after his talk. Jürgen, thank you.
Right, thank you, Christoph. Ladies and gentlemen, so my case is obviously all about co-infection. This is my disclosure. So my first question to you is really, do you treat co-infected patients in your clinic? Just to get a feeling, does someone also see co-infected patients? And so you can either exactly show up or you can use the app, and I think that's great. So I see there's considerable people who enjoy treating co-infected patients, and that is very helpful. All right, so my case here is Volker, a 40-year-old man who has sex with men. His HIV was diagnosed in 2002. It was diagnosed early during seroconversion, which really doesn't happen that often, and got a relatively, from current view, probably relatively toxic regimen with AZT3/TC boosted lopinavir, was suppressed, and was eventually switched later on the course to something more tolerable, Truvada plus boosted fosmanogeprenavir, and you can see he's doing very well. He's still suppressed. There's a high CD4 count. But then in 2010, he did acquire acute hepatitis C. It was a genotype 1A infection. Viral load was 2.7 million. He had an IL-28 CT, and after 4 weeks, hepatitis C viral load was 288,000. So my question for you would be, would you treat acute hepatitis C, yes or no? And if yes, would you do that with pegylated interferon and ribavirin, or would you treat with DAA-based interferon therapy? So vote now, and I think you have the chance to use the app, and then we'll see it up here, I think. That's how it should work, right? And there's no music, as usual, with our questions. That's all I know. I can sing you a song, but you may be leaving the room faster than my co-speakers would enjoy, so because they still have their cases to present. So are we going to see the results up here? Or no?
I'm not quite sure whether the voting system is in place and works. So perhaps we have to estimate with raising hands or no, something like this.
Oh, okay, I see. All right. Well, let's have a show of hands. Who would treat? And who wouldn't treat? All right. So there are more people who would treat than not treat. So there has been a consensus statement. So obviously, the first thing you wonder when you decide you want to treat or not is that there is a probability of spontaneous clearance, and so obviously you don't want to treat someone who may clear infection himself, and there are some factors which are predictive for that, and that's in particular IL-28B CC genotype and some other issues, and also how fast your hepatitis C viral load changes over time. Now, in the guidelines from EASL, and you will see the same in the co-infection guidelines from EX, there still is only a recommendation for pegylated interferon. In the case of acute hepatitis C in monoinfected patients, that would probably be just a monotherapy with pegylated interferon, and then in the setting of co-infected patient, ribavirin is added, as there has been some work suggesting that there is a faster decline in hepatitis C RNA with ribavirin. No DAA so far has been licensed for the indication acute hepatitis C, and therefore there's no reimbursement for that particular setting. This is the algorithm, as you can see, depicted in the current guideline version of the European AIDS Clinical Society. And basically, the rule of thumb is that when you diagnose someone with acute hepatitis C, and remember, from a diagnosis standpoint, the most important thing is that usually you see someone with newly elevated liver enzymes. If you do hepatitis C antibodies, you will often miss the diagnosis because it can take up to a year in a co-infected individual to develop those antibodies. So usually it's elevated liver enzymes and hepatitis C RNA being positive, which leads to the diagnosis. And then we recommend to wait 4 weeks. If you have a more than 2 log drop, that was what the European large cohort of acute hepatitis C patients with HIV suggested, you have a very high chance of clearing infection, and as such, you would then rather wait for spontaneous clearance to happen. If you do not have a 2 log drop at week 4, after your initial hepatitis C RNA measurement, it becomes very unlikely, and as such, it would make sense at least to offer therapy. Now, in those days, in 2010, we did offer therapy because his viral load did not drop 2 logs, and after 4 weeks, after 4 weeks of treating him with PEG and Riba, he still had a viral load of 1,655. The thumb of rule is that if you are undetectable at week 4 after starting treatment, you can shorten treatment duration in co-infected individuals for 24 weeks. If it's still positive, then would be a 48-week cycle of interferon ribavirin, which he received. But you can see that at the end of treatment, he was still replicating, suggesting that this was only a partial responder because he did have some decrease in RNA, more than 2 log, but not achieving undetectability. He has now, in 2014, normal fibrosis on FibroScan evaluation, 4.6 kilopascal. His liver enzymes, however, are still remaining elevated, 5 times upper limit of normal, and he's complaining of increased fatigue. He feels that his working capacity is reduced. It's only work, and so he's losing sort of quality of life. And as such, he is asking about treatment options. So should we treat chronic hepatitis C now in Volker, 4 years after his acute hepatitis C and failing on interferon ribavirin therapy? So maybe we can see a show of hands here. Who would treat or offer therapy in the setting? All right, things have moved forward from year by year conference, that's for sure. All right, so everyone says yes, let's treat. Now, obviously, in the setting of co-infection, there are various reasons why you want to treat, and one is that in large cohorts like Eurocida, where you have 18,000 HIV-infected individuals, if you look, first of all, at the prevalence of hepatitis C or positivity, in Eurocida it's 31%, reminding us all how often co-infection occurs in the setting of HIV, and then note again that 74% are only RNA positive, so there are quite a number who cleared infection, many of them, though, got infected with hepatitis C first and then had HIV. And if you look at the progression to liver-related death, you can see that indeed patients who are positive only with antibodies already alone have a significantly, dramatically enhanced risk of dying from liver disease, and that becomes even higher if you are obviously replicating as a sign of ongoing replication. And so that high toll of liver disease and mortality is clearly one of the underlying reasons why you want to treat. And then I think the rationale for the prioritization of co-infected patients for treatment of hepatitis C really comes largely from this cohort analysis from the veterans group, which compared patients who were co-infected versus mono-infected. And what they did is they looked at co-infected patients who were on combined antiretroviral therapy. So many studies before have shown that if you actually give HIV therapy, you can slow down that faster fibrosis progression. So the question would be, well, if I have co-infected individuals, put them on HIV therapy, do they then have the same fibrosis progression rate as those who are mono-infected? And so they compared the rate of hepatic decompensation between these two groups, co-infected on HIV therapy and hepatitis C mono-infected in large patient numbers, and you can see that the curves separate and that the risk of hepatic decompensation remains much higher in the co-infected patient group. And actually, if you go into a sub-analysis of that study, you will see that particularly those who have a very low CD4 count and those who are not completely suppressed under their HIV therapy are those with a particularly enhanced risk of developing hepatic decompensation. And that is the reason why in the guidelines, as listed here, in the EASL guidelines, but also in the ACLD guidelines, you see a prioritization of patients with co-infection. So beyond the fibrosis stage, people recommend to treat co-infected patients because of that unique higher risk of liver disease occurrence and faster fibrosis progression. And there are many countries like Brazil where co-infected patients, all independently of fibrosis, will receive hepatitis C therapy. So that, I think, is a good move forward for this particular patient group. Okay, so we're all on one page. We want to treat the patient. After all, he has suffered through 48 weeks of interferon. He really has showed his motivation. So which hepatitis C therapy would you suggest? And I think now the voting should be working. So if you have the app, try that. Would you give sofosbuvir peginterferon, sofosbuvir ledipasvir, sofosbuvir decladisvir, sofosbuvir cimeprevir, or the every 3 drug regimen? And remember, it's a genotype 1A, and the viral load was around 4 million. All right. So no one would give interferon, all right? And there's a balance between sofosbuvir and either ledipasvir or decladisvir, and fewer for the combination with a protease inhibitor of the every 3 drug regimen. But basically, all regimens sort of appear, and I think that sort of makes sense. You see here the table of the co-infection guidelines from EACTS, where you can basically see all the various options listed. So in theory, all of the answers are at least correct, because all of these regimens are listed as potentials. And just starting off historically, obviously the largest study to date in the setting of co-infection, but with a regimen we would not recommend in genotype 1 patients, is sofosbuvir and ribavirin. And you see here that in non-cirrhotics, at least, we did achieve quite impressive response rates in the genotype 1A patients of 87%, but obviously that is lower than what is achievable with an all-oral combination therapy, and as such, we would not recommend that. But that was already the first study, I think, suggesting that efficacy of DAA therapy is very similar in co-infected, likewise to mono-infected patients. This is the summary slide of the Turquoise 1 pilot study, which our wonderful chair Mark led in its effort, and you can see here the overall cure rates, which were 94 and 91%, so they compare 12 and 24 weeks of the every 3 drug regimen plus ribavirin, and you can see very good response rates. Similarly, high response rates were also seen, 97% under the combination of SOF and decladisvir, 12-week treatment, and that was true for naive as well as for treatment-experienced patients, so suggesting that even more difficult to treat patient population still came with astounding high response rates. And I think for those who are co-infection treaters and come from the era where they use interferon ribavirin, and we were always treating longer and with higher dosages, and with so much toxicity and issues and challenges, it is just, I think, a wonderful change in clinic that suddenly we can use the same short durations and achieve the same high cure rates, which obviously for our patients is fantastic news altogether. The same has been seen in the ledipasvir sofosbuvir fixed dose combination trial of 12 weeks. Again, 96% cure rate. And you can see that even in the treatment experience and also in the cirrhotic patients, so there was a small number of 67 patients included with cirrhosis, you see similarly high response rates. So that, again, goes over more challenging to treat patient groups and really is reassuring for clinical practice. Now, our patient is on Truvada, so tenofovir FTC plus boosted fosamprenavir. So let's say we want to choose ledipasvir sofosbuvir because of reimbursement issues in our country. Could we combine that with his HIV regimen? Yes or no? So who would say yes, no problem? And who would say no, may be an issue? All right. All right. So the majority would say, actually, there is an issue. Mark, what would you say?
So the concern here,
You have to push the button, I think.
I don't have a button. I thought you meant.
Maybe you know the microphone.
I thought you meant voting. I didn't get the app, so I can't. I'm not represented there on the 8 votes that we've got. But I would have probably picked no, primarily because we have been concerned about the potential for the ritonavir-boosted HIV-1 protease inhibitor to increase ledipasvir concentrations. Now, that said, we have treated some patients and been successful, but if there's an alternative HIV regimen, we've often taken that route.
Yeah. So I think that's interesting because, so let's walk through the data. So there are various sites you can use for looking. Obviously, the Liverpool website is a great asset, but there's also an interaction scorecard, and I got this from Jennifer Kaiser. And the advantage of this scorecard is obviously I can put it into one slide and you see all the interactions. So that's why I use that one. And you can see that indeed, if you look at the where do we have it? The ledipasvir and the boosted PIs, there is at least some yellow flagging, which basically refers to the fact, we see that also in the tenofovir, marking that ledipasvir actually does increase tenofovir levels. And the question is, how relevant is that? But you know from clinical trials that if you give a boosted PI, you also have an increase in tenofovir levels, and that has been associated with more renal toxicity. So overall, in cohorts, boosted PI plus tenofovir seems to go in hand with the highest risk of toxicity. Now you can say, well, if someone has a complete normal renal function, is that going to matter? And I think that could really be discussed. I think, though, what we appreciate is that, particularly when this data was shown for the first time, and in a clinic, when we started to use these agents, we're more prone to treat patients with cirrhosis, and some of them would have had hepatorenal syndrome and have sort of a borderline renal function, and that's, I think, where we were always sort of concerned and worried. So I think we'll have to separate a little bit. Do you have renal function which is normal up front, or do you already have a patient with a history of issues? This is the slide from Croy, which summarizes the effect of ledipasvir sofosbuvir on tenofovir PK, and you see there are moderate increases in tenofovir exposure, and so if you already have an increase through the combination of a boosted PI and the tenofovir regimen, then that's going to increase another 30 to 60%. And the question is that clinically relevant or not? Now remember that in this IN4 study I showed you, no boosted PIs were allowed in that study. So we don't really have an answer. There were only 4 individuals out of 300-something who developed renal toxicity. 2 were able to be maintained on the regimen, 2 stopped their tenofovir in that trial. So little signal of toxicity, but there were some patients. So it is, in the end, I guess, an individual decision. Now, in our setting, because we were not so sure, and because the patient was naive and he was started on a boosted PI, which doesn't necessarily have to be a primary choice, we decided to play safe and to switch the patient to tenofovir 3-TC and raltegravir, just to make sure that we don't have to worry about these issues at all. And then he received his 12 weeks of ledipasvir sofosbuvir. Now you see that he responded quite favorably. He, though, was not negative at week 4, so he still had 42, something which we see in clinical practice quite frequently, although also I think it's important to highlight that whatever result you get depends very much on the viral load assay you're using. So we use the Abbott assay, and we see more positive results with that assay. But you see at the end of treatment, and also 12 weeks after stopping therapy, the patient is undetectable, but then he shows up again 4 weeks later, and we do another control, and he has viral load of 194,000 copies, and a repeated genotype analysis shows it's the same genotype. So what is your diagnosis? Late hepatitis C relapse or reinfection? So vote now. Well, there are only 3 votes. All right, so this is a living voting process. All right, so it's split. So, I mean, it basically could be both, right? I mean, it's the sort of the question we obviously have. Now, so the question is, how can you address that? So obviously, in the setting of a man who has sex with sex and acquired his hepatitis C through traumatic sex practices, at least if that behavior remains, there is a clear risk of reinfection. The rate of reinfection in the European acute hepatitis C cohort, which is all MSM in that setting, is 25% in 2 years, so not that unlikely. Rate relapses beyond week 12 are extremely rare. I only know of one published case, so that is not very likely. But how are you going to distinguish that if you have the same genotype? So many patients, when they get reinfected, have a different genotype, and then it's sort of easy, but it wasn't that easy. So what I did was I sent blood to Christoph Sarrazin's lab, which is kind enough to do that without any cost, which is wonderful. And, and so the genotypic resistance test showed wild-type infection. And so that obviously hampered the question, and it tells you how difficult that is, because so the question now is, are we going to retreat the patient, or are we going to say the behavior is not changed and it makes no sense to treat again? So I said, do you think that you had a sexual transmission risk? And he said, no. But he already said that in the first case, and that makes it difficult, right? He never thought he was at a risk. And although we went through how you could possibly contract it, it turned out, though, that he had a merry weekend with 6 friends, which was related to having sex as a group. So there was at least a potential risk situation. And then I looked into the wonderful analysis from Eric Lawitz, which looked at patients who failed on 8 or 12 weeks of ledipasvir/sofosbuvir, and then looked at retreatment for 24 weeks. And if you look at the bottom of the table, you will see that of those patients who failed after 12 weeks of soft ledipasvir, every single one had NS5A mutations, which for me tells me that the probability of him failing, being suppressed all the time on therapy, but having no, because if he wouldn't have taken it, then adherence could have been another reason, but having absolutely wild-type infection suggests to me that it really is a reinfection with the same genotype. So that was my conclusion of that. Would you agree with that, Christoph? Or?
Yeah, I think there's a high likeliness that you're right. I mean, 16 weeks, you tested him after 4 weeks earlier, follow-up 12, and he was undetectable. So the relapse could not have been months ago. It has to be within that 4 weeks. It has to be happened within these 4 weeks. And then I would expect that we will find these NS5A resistance. As you said, in the studies where we have data, the rate is almost 98 to 100%. So it would be extremely unlikely, and therefore the likeliness that this is a reinfection is high. I agree.
Jürgen, did he have any other symptoms of any kind of acute infection? Were his transaminases any different than they had been suddenly?
Yeah, so his transaminases normalized. Remember, when he started therapy, they were 5 times upper limit of normal, and upon a reinfection, they were elevated again. And that in a higher manner, so they were like...
But he didn't feel, symptomatically, he didn't notice anything.
Well, let's put it this way, after a weekend of partying and sort of naturally some element of fatigue, I guess. But he had no jaundice, so he wasn't jaundiced during infection. And he had liver enzymes which were around 200, 250. So that was pretty much it. All right, thank you.
So what did you do with this patient?
Yeah, so what I did is, so I have to say he was referred to from a primary HIV provider from Cologne. And so I called him. I said, we have to speak with the same voice here, because otherwise it makes no sense. Because obviously the patient realized works for an academic institution, he has a university degree, and so I think he was willing to say this is a relapse so that he could put a point on getting treated. And he made that point with his primary care provider. And I said, I don't really have the feeling that there is any willingness to change behavior at all. And that, for me, considering the cost of the therapy and having no fibrosis, I have to say, I feel it's not the right moment to retreat, because I just cannot guarantee that this is sustainable. I think that medically, with an F0 fibrosis, there is no strong urgency to push the limit at this point. So I said, I think we're just going to wait. I mean, obviously, I would love to include him into clinical trial, because that would sort of take away the cost pressure. But I think, you also have to be fair. All of our HIV, HCV co-infection trials have in their analyzability issues at the end, because there are reinfections. There were 2 in the Turquoise 1 study, which had only 63 patients, right? So, I mean, 2 of 63 which in the 12 weeks after stopping therapy had a reinfection. There are 2 cases in the co-infection C-EDGE study. So we're not even talking week 16. We're talking between stopping therapy and week 12 after therapy. And so that's also for clinical studies has been an issue because you are impacting your overall SVR rate. So I think there is an issue, and there's obviously a lot of discussion in many different groups, and it depends a little bit on which country you're coming from. So there are countries which say you only have 1 shot of treatment and you're not going to be treated again, simply as that. In Germany, there is no law which says you can't treat as many times as possible, but in a certain way, I just don't feel strong. So I said, I'm going to wait, and the patients, because we had an open discussion, said I continue to have sex the way I have it, and as thus he remains at risk, and I don't really see how we can face that.
In a way, you could have punished him by telling him that he has now acute hepatitis C, and there's only 1 approved treatment in Germany, and this is Pegriba for 24 weeks.
Yeah, but since he hadn't responded to the first cycle of Pegriba, that would be a real punishment. Yeah. The German approach.
Questions from the audience?
Hi, I was interested that you chose to change the HIV therapy to accommodate the HCV therapy. How do you decide whether to change the HIV therapy or to select a non-ladipasvir based therapy?
Yeah, so in Germany, the first question is always, what is reimbursed? So in that specific time slot where he was being treated, the AbbVie regimen, I think, was not there already. The Cladisvir was in sort of the compassionate use, and there was not the same reimbursement process for genotype 1. So in a free world, you may decide differently, because you could have said, I'll just use a different regimen. I think that would have also been a possibility, but that possibility in Germany starts always with the question, what is in the label and what does our regulatory sort of system allow for reimbursement? So it's beyond the patient characteristics in the end. It's really about, who's going to pay the bill in the end, right?
Prior question, how often do you change to or switch to integrase inhibitors before HCV treatment?
Yeah, so I think we also have to reflect that this was in the early days of the licensing of ladipasvir, and we just simply didn't know. I think today I would probably be not that much driving into change necessarily, just because I think that if someone enters with a complete normal function, he has a much bigger chance of tolerating tenofovir in the setting of not having cirrhosis. So the aging patient, the diabetic, the hypertensive, the one with end-stage liver or renal disease are obviously the ones where you would face different issues. I think, though, that in the context of co-infected individuals, you see that there is, in general, a strong move to use integrase inhibitors. And I think there's a very strong rationale for that. And one of the main reasons for that is that basically we're seeing increased evidence that probably fatty liver disease is of great concern. HIV may induce insulin resistance. There is direct infection of hepatic stellate cells and Kupffer cells through HIV. So there's a lot of reasoning that there may be, over decades of therapy, an issue with regard to liver health, and as such, using agents which are liver neutral, I think, make a lot of sense. Boosted protease inhibitors, particularly those of the older days, like lopinavir causing insulin resistance, may not be the most optimal choice to a certain degree. However, in the past, because predominantly our group of patients were IV drug users, because of the high genetic barrier, we wanted to use protease inhibitors, right? That was the main reason, because we thought, well, if they don't take the drugs or get into a little drug experience over the weekends, it doesn't really matter. But now that we have integrase inhibitors with a high genetic barrier, I think that's also changing. So I think there's a strong push to use integrase inhibitors in these patients increasingly.
Great. We'll take one last question in the back.
Jürgen, the flip side of the discussion around deciding whether the patients need to be retreated is, quite as much as he was reinfected, he could potentially now infect others.
Yeah, I think that's an absolutely fair point. But the question is, in the end, is it cost effective to treat someone so that he prevents infection of someone, but then he gets infected again? So the protection, the period of not infecting someone is limited to 24 weeks. So is the 60,000 euro treatment every 24 weeks justified to prevent X infections? We can't say anything to that. And there are a lot of modeling approaches, and I think one of the big questions we have, obviously, in the field is, what if we can treat acute hepatitis C with a DA-based regimen, and let's say in the best sense, or the best scenario, it would be a 6-week treatment. So it would be shorter, it would be attractive to treat them because you would save money. And let's say we could demonstrate that. Wouldn't that make sense to treat them all because you don't have the 50% who don't want to be treated with interferon, and then you could actually shape the epidemiology because all these HIV patients who seem particularly at risk of getting hepatitis is a small group, it's well defined. They come for HIV, viral load, and CD4 count control, so we pick up acute hepatitis C very, very rapidly, and couldn't we then eradicate that in this group? And I think there are many efforts to address that, and I see some hope in some research projects around that, but first we need to know, can we use DAs in that context? So that's current work in progress.
So certainly an area of additional research before we have a strategy for treatment prevention. So with that, we'd like to thank Jürgen. We'll let him start his vacation officially now.